TCD Techniques and Tips. My name is Aisha Upal, and I'm the TCD Product Manager for Natus Medical. I'm proud to be hosting today's session in conjunction with our education team. In a moment, I'm going to introduce you to our speaker and presenter, Katie Vollrath. Now I will introduce our speaker, Katie Vollrath. Katie began her career in TCD in 1989 and has been with us at Natus as a TCD clinical specialist since 1996. She has presented TCD at multiple seminars and conferences and has vast TCD experience. Katie has been honored as a fellow with the Society of Vascular Ultrasound. She has served as president of the SVU and remains active in the SVU. We welcome her today as she speaks on our TCD techniques and tips. I will hand the presentation over to you now, Katie. When her presentation is finished, we will have time for questions.
Well, good afternoon. Thank you, everybody, for joining us this afternoon for our discussion on transcranial Doppler techniques and tips. This is the beginning of our third year of doing these TCD educational webinars, and we've had so many wonderful speakers, so many great pathology subjects. But what we do, and we hope that you'll continue to send this in, on our survey, we ask, are there other subjects that you would like to hear addressed? And what has come up repeatedly is a review of how we teach TCD technique on the Sonara. So we'll be covering basic TCD technique today, as well as some tips for vessel identification. So when we talk about a basic TCD, we use three approaches. We use the transtemporal approach, the transorbital approach, and the suboccipital approach. For the transtemporal approach, we are evaluating the anterior circulation as our primary goal. For the transorbital approach, we're evaluating the carotid siphon. For the suboccipital approach, we are evaluating the posterior circulation. And the submandibular approach is something we'll talk about at the end. It is not normally part of a complete TCD exam, but is added in some situations. So let's start by just an understanding of the basics. Anybody trying to do a TCD exam needs to be familiar with the flow direction of each artery. Every artery has a known flow direction, and you need to know the expected normal depth to find those arteries, and that's what's illustrated in this slide here. So let's talk about the transtemporal approach. The transducer is oriented along the temple above the zygomatic arch, as illustrated here. From this approach, we're going to expect, as long as these are anatomically present, we did have a seminar recently on collateral flow and anatomic variations, but as long as the patient has all of the arteries in their right places, we expect to find the middle cerebral artery, the anterior cerebral artery, the terminal ICA, or the TICA, and the posterior cerebral artery, or the PCA. That's what we expect to find in a normal exam. The only time that we'll find the anterior communicating or the posterior communicating arteries is when the patient has collateral flow. Otherwise, they are not part of a routine exam. Question also arises, how do I know that I'm on the artery I want to be? Well, you need to be very cognizant of the depth of your sample volume. So as I mentioned, and as we'll review, every artery has a known range of depth. Every artery has an expected normal flow direction in relationship to the orientation of the transducer. Each and every artery can be traced along the course of the artery or from one artery to another artery. In tracing from one artery to another artery, we need to be very aware of our transducer angulation as well as spatial relationship of the spectra. Let's start with the transtemporal approach. we start on the middle cerebral artery. By the way, this is from Dr. Oglet and Dr. Spencer's ways of teaching back when TCD began, so that's how we chose a starting depth of 50. It's from that literature. So we start at 50, and that puts us, as you can see with the little box there, right in the middle of the middle cerebral artery. The mean velocity listed here, 55 plus or minus 12 centimeters per second. These are typical velocities. Patients can have variations in this. Patients can have slightly higher flow velocities than listed here or lower, just depending on their own hemodynamics. But what we want to observe in this situation, we see that our mean flow velocity is about 60 here, and our waveform is above the baseline, indicating flow towards the transducer. Let's look at that same artery. This time, we're adding M mode. So M mode allows us to have an idea of where is the artery patent and other landmarks. So in this situation, we see our cursor is in the M mode, which is this area above the waveform. Our cursor is at 50, and if you look down at our waveform information, our depth is shown at 50. But M mode gives us so much more information. M mode shows where there is flow. So anywhere that we have color filling, we will get a Doppler signal. So in this situation, I can see that the M mode for the MCA, flow towards the transducer, is in red. We're going to be able to get flow all the way down to about 42 and all the way to about 64. And then right about 64 should be our MCA-ACA bifurcation. And it shows us that we have a patent ACA also from depths of about 64 to 80. So that's why I love the M mode. I use it every time I do an exam or teach TCD technique nowadays. After we document the middle cerebral artery, we want to decrease our depth and take a snapshot of the distal MCA. You want to be able to trace that at least down into the low 40s. In this instance, we were able to get a lot less in depth than that. We were all the way down to 32. Go ahead and document with a saved waveform your most distal MCA. You could say, well, why do I have to trace this distally? Two things. We're looking for pathology, and if we don't look at each depth, we usually go down by 2 millimeters from 50 to 48, 48, 46, et cetera. This is how we're going to find our pathology. And then secondly, by tracing distally, I verify that I am actually on the middle cerebral artery and not the terminal ICA, which is a common mistake. If you try to trace from 50 distally and you can only get down to a depth of 48 or 46, in all probability, you're not actually on the middle cerebral artery, but rather the terminal ICA. So that's another reason we trace, is to make sure that we're actually on the middle cerebral artery. After we've traced and taken a picture of the distal MCA, our next step is to return to a depth of 50, and now to increase our depth until we encounter a waveform that looks like this one that just came up. So on the top is the middle cerebral artery with flow towards the transducer, and on the bottom is the anterior cerebral artery with flow away from the transducer. Notice that the flow in the MCA is higher than flow in the ACA, and that is the normal expectation. We take a picture of the bifurcation, and the reason that we do that is to document this flow relationship of higher in the MCA, lower in the ACA. And also, the bifurcation is a landmark that we're going to use over and over and over again, so we want to have that depth documented so that we can go back to that depth again and again. So one picture of the bifurcation. Now here is the same picture, but this time we're showing you the M mode. So you see that our cursor is actually right here in between the red and the blue, and that's why we're getting flow in both directions. So again, the M mode really helps with vessel identification and verification. A lot of times people ask, how do I find the ACA? Well, when you're at your MCA-ACA bifurcation, that lower waveform is the ACA. You don't have to search for it. It's there. The ACA is typically located at depths between 60 and maximum of 80 millimeters. And the typical flow velocity is lower than in the MCA. It's typically 50 plus or minus 12. So we want to take a snapshot of that anterior cerebral artery and save that. So you see here that now the flow that we're interested in is this waveform below the baseline. And above the baseline, we have this little branch. We're not particularly interested in that, but you will see these branches appearing intermittently throughout your interrogation of the MCA bifurcation and ACA. This is the same picture on, actually it's not the same picture. Here we are a little deeper on the ACA, and you can tell that by our depth is now 70. Our waveform is below the baseline, and notice our branch has pretty much disappeared by now. It's there, but very, very faint. And our M mode shows that we're in the blue, which is flow away from the transducer. So we took a picture at the bifurcation. We want to go a little deeper and take a picture of the ACA, which we have here. And then we can trace all the way into midline. You're saying to yourself, we don't do that. Why would we want to do that? So our depth is increased to somewhere between 75 and 80. And what we can see here is the ipsilateral ACA with flow below the baseline, but then this shadow of flow above the baseline is actually our contralateral ACA. So this is very helpful in finding collateral. So the only way that I'm ever going to see collateral flow is actually to increase collateral ACA crossover collateral flow is to actually increase my depth until I get to midline, and that way I can visualize it very easily with flow going in the opposite direction of normal. Now this is the same normal bifurcation of the, this is a bifurcation of the ipsilateral ACA and the contralateral ACA, but now we've added M mode to that. I love this M mode. It gives us a lot of information. So in looking at the M mode, the arrow that you see right now is the depths of my ipsilateral MCA. This is the depth of my ACA, and this red is actually flow now coming toward the transducer from this contralateral ACA signal. So again, M mode is very, very helpful. Why do I keep saying that? A lot of people don't understand how helpful M mode is, so that's why I'm emphasizing that at this point. Okay, now it's time to go back and look at our protocol and note what was the depth that we found our MCA-ACA bifurcation at. Because the next artery we're going to identify is the terminal ICA or the TICA. And we see it here on our screen. We have our terminal ICA is flowing toward the transducer, and I want you to note that the mean flow velocity is slightly lower than we had at the MCA, and that is to be expected. So when you are looking for your terminal ICA, return to your depth of the bifurcation, as we see here. And then you want to orient your transducer slightly inferior to pick up your terminal ICA. After documenting the terminal ICA, we are going to return to our bifurcation depth once again. And now we can locate the P1 portion of the posterior cerebral artery, the PCA. It's going to be a good landmark to use as your bifurcation landmark. That's going to put you in your depth, suggested depth of finding the PCA at 60 to 70. I want you to notice that the mean flow velocity is much lower than either the MCA or the ACA. Typical mean velocity is 39 plus or minus 10. So in the example that we gave you, let's think back. The MCA had a flow velocity of about 65, the ACA of about 60, and now the PCA has a flow velocity of about 47. So that lines up very, very well as far as normal waveform and relationships as far as velocity. All right, so that's P1. Let's take a look at it. Here's where we're looking for the P1 portion of the PCA. Let's look at this in M mode. This is one of my very favorite uses of M mode. So if you look at the M mode, now notice that what we have is a red band in depth from about 56 to 78. And I want you to notice what's missing. We do not see any evidence of the middle cerebral artery here. So to find our PCA from the bifurcation, what we do is we tilt the transducer first posterior and then inferior. So we're tilting out of the anterior circulation into the posterior circulation, and that's why we no longer see our MCA. All right, now we can also trace the PCA into midline, and that's what you're seeing here. So, well, this is interesting. There's my, okay, I have to go back. That was real interesting. I think my slide got goofed up. What you should be seeing here is the circle of Willis, and we're showing you that we're at midline at a depth of somewhere between 70 and 80. But looking at the waveform here, and I apologize for that. So this is our ipsilateral PCA, and the one below the baseline would be our contralateral PCA. And again, why do we do this? We're looking for pathology. We can also find P2. Sometimes it's in our protocol to find P2, and other times we find it by accident. So if you intend to find P2 from P1, you would rotate your transducer more posterior, and we're looking now at P2, and we are not changing our depth, but rather rotating more posterior from P1. And you'll see your waveform towards the transducer disappear, and you'll see a waveform below the baseline or away from the transducer appear, and that's P2. Sometimes when we move from the bifurcation posterior and inferior, we end up in a waveform that looks like this, and that would be P2. So then if we just rotate slightly back anterior, we should go back into P1. Let's show you this on the M mode, and again, it'll help you to verify where you are. In M mode, the P2 portion now is going to show up in blue instead of red when we're in P1. All right, let's put these all together. So we've got the P1 portion of the PCA with flow towards the transducer. We can trace that into midline and see flow in the ipsilateral PCA as well as the contralateral PCA, and then we can rotate a little more posterior and pick up P2. And here we are. Big question. We said we'd give you some tips on knowing what artery you're in. One of the, if I go back to a site that I've trained and I say, can I help you? Any questions? They'll say, we're having real trouble knowing when we're on the PCA or not. And you're not alone. So there are a number of tips, but the best one when you are learning to do TCD comes directly from Dr. Oslett. Dr. Oslett is the one that invented and first introduced TCD back in the 80s. The PCA perfuses the visual cortex. So when you have moved from your NCA-ACA bifurcation into your PCA by tilting posterior and inferior, you look at your waveform, and stimulation of the visual cortex causes an increase in blood flow via the PCA. How are you going to stimulate the visual cortex? You're going to turn on and off the lights. This is called metabolic autoregulation. Let's show this to you. So here's a situation where we're on what we believe to be the PCA, and we then turn on the lights, and we see after a few seconds our flow velocity increases. Dr. Oslo said that the flow velocity will increase anywhere from 10 to 16%. Then, when we turn off the lights, right here, our flow velocity goes back down again. Now, I've got to warn you about something. I wouldn't do this in the ICU. I'm going to go back to that slide. I wouldn't try this on patients in the ICU because these patients have lost metabolic autoregulation and they won't be able to respond to changes in lights. So the usefulness of this is for those of you that are teaching TCD or those of you that are new to TCD, check your technique by turning off and on the lights, and you'll see these changes in velocity, and it will help you to perfect the technique of that posterior and inferior tilt into the PCA. All right, next approach is the transorbital approach, and you don't have to do these in this order. I usually start with the transtemporal approach, and then I go either to the transorbital or to the suboccipital, but for our cases here, we're going to go to the transorbital approach next. So in this situation, we're evaluating the carotid siphon and the flow direction in the ophthalmic artery, and we're going to place the transducer over the closed eye using a very light touch and very little gel. The FDA recommendation is that we must reduce the power to 10% or less when passing ultrasound through the eye. With the Sonara, your protocol automatically reduces the power for you. Now, how can we do that? We use 100% power half the time when we're going through the transtemporal and even the vertebral basilar arteries. Well, when we look at the orbit, you see there's these two orifices here. One of them, this one here, is where the ophthalmic nerve, the optic nerve inserts, and this is the optic artery. So we've got these actual little holes that we're passing ultrasound through, and thus we don't need as much power as we do when we're at the areas that have bone. So this is our ophthalmic artery. Typically, the depth that we're going to be able to find the ophthalmic artery at is 40 to 60, but we generally just acquire one waveform at a depth of 50. I want you to notice that the mean flow velocity is much lower than anything else we've talked about, 21 plus or minus 5 centimeters per second. I also want you to notice that flow in end diastole is quite low compared to any other of the arteries of the circle of Willis that we've looked at. That low flow in end diastole creates a high pulsatility index, and that's because in a normal situation, the ophthalmic artery is not perfusing the brain. It's perfusing the eye. So we're not going to have as much flow in the ophthalmic as we would in our arteries of the circle of Willis under normal circumstances. After we locate the ophthalmic artery and take a picture at 50, we can begin to increase our depth, and somewhere generally after 60 and before a depth of 74 or so, we are going to encounter the carotid siphon. So there's a lot of variability on where the siphon inserts, or where the ophthalmic inserts into the siphon. So what you want to do is just begin to increase your depth until your waveform changes from this high resistance waveform to a waveform that looks more like your arteries of the brain, a low resistance, high diastole compared to the ophthalmic artery flow. Typical mean velocities are 47 plus or minus 14, and you notice here that your pulsatility index is back down within a normal range of 0.8 to 1.2. This is the paracellular portion of the carotid siphon. Let's show you where that is. So the paracellular is the one with the flow coming toward the transducer. The supraclinoid is right here with flow going away from the transducer. The genu is here at, oops, I'm pointing and not showing you guys what I'm pointing at. Here's the genu. It's an actual curve, which means knee in Latin. So we're going to get flow in both directions at the genu, flow away from the transducer at the supraclinoid portion, and I already showed you the paracellular portion. After we document the transorbital approach, we can proceed to the suboccipital approach to evaluate, or the transforaminal approach to evaluate the vertebral arteries. There's two of them, and the basilar artery. The vertebral arteries typically have again, a lower flow velocity than either the MCA or the ACA. The PCAs and the vertebrals, the basilar, all run very similarly, but typical flow velocity 38 plus or minus 10. We begin at a depth of 60. I know some labs begin at different depths, but that's the technique that we learned from Dr. Oslitz. And we see that the mean flow velocity here is 31, and the flow is away from the transducer. Let's look at the same waveform in M mode. Now, we get a lot of information here. We see color filling in our M mode all the way from 60 to about 80. This tells me, by this M mode being filled here, that I am going to be able to trace my vertebral artery from 60 at least towards 80. And you want to do that. So take a picture at 60. Take another photo deeper within the vertebral. I usually take one myself about every 10 millimeters unless I encounter pathology. Here's a saved waveform at a depth of 74. And you see this flow below the baseline is what we're tracing. That's the vertebral. This is a branch above the baseline, and we will encounter branches frequently. That's okay, but we are concentrating on the flow below the baseline, which is the vertebral artery. We're going to trace on up to 78, and then when we reach 80, we're going to change our vessel label to the basilar artery by hitting next in our protocol. You see the basilar artery here has flow away from the transducer, and the mean flow velocity is 41 plus or minus 10. So when we have two good vertebrals that merge into the basilar, we'll have a flow velocity that's just a little higher than either vertebral. We want to take a picture at 80, and then we want to trace this waveform deeper. But before we show you that, let's just show you the M mode. And here we are showing you our basilar artery. Here's the M mode. So again, our same waveform at a depth of 80 that we were looking at a moment ago. But here's the information I get now from M mode. I can tell here's where I am at 80. But by looking at this M mode, see all the blue filling here? I know that I'm going to be able to trace this very easily, at least up to about 110. And then with some slight adjustments, I should be able to trace it all the way to 120. So here's our distal basilar artery. This time we took a snapshot at a depth of 100. Okay, now that would be a complete TCD exam. So we've covered the transtemporal, transorbital, and suboccipital approaches. We've documented our waveforms. Sometimes we've got situations here where some labs always do the submandibular approach, which is insunating the middle cerebral artery, which we do anyway, but then comparing that to the extracranial ICA. This is called the MCA-ICA ratio. On your Sonara, it shows up under summary as LR. That LR stands for the Lindegaard ratio. Let's talk a little bit more about this. We've gone into detail on this with our discussions on vasospasm, but where we're talking about technique, we thought we better include this again. So the idea of this is patients in vasospasm are receiving therapy to try to increase flow. So one of the mechanisms that they do, for instance, is they can make the patient hypertensive through pharmaceuticals. Now, if we're raising the patient's blood pressure, then flow will go up in the brain, and it will also go up throughout the whole body globally. So what we're doing is we are comparing the extracranial ICA information to the MCA information. The transducer is placed underneath the jaw at an angle of 0, and the extracranial ICA waveform is taken at a depth of 50. This puts us still in the extracranial circulation. We're not up in the circle of Willis, we're down in the extracranial ICA. Let's see how this works. In a normal individual, here's an example, patient in MCA is 63, the extracranial ICA is 37. This gives them a ratio of 1.7, and that's well within the normal range. Now, in a patient who went into vasospasm, and now they're treating the patient by pharmaceuticals to raise their blood pressure, more volume expansion type drugs also. The question is their vasospasm getting worse, or do they have a hyperemic increase in flow? So let's look at this example here. This patient has an MCA of 140, the extracranial ICA of 50, and they have a ratio then, that MCA divided by that extracranial ICA of 2.8. This tells our interpreting physicians that flow is high globally. It's high in the neck. It's also high in the brain. That is the hyperemia because that ratio is less than 3.0. Ratios that are greater than 3.0 are consistent with spasm. And here's an example of severe spasm. The patient has an MCA flow of 220, an extracranial ICA of 32. This gives them a ratio of 6.8, which correlates with then severe spasm. So that's that fourth approach of the submandibular. And again, just reviewing those categories of hyperemia, spasm, and severe spasm. So that would be our complete exam. Just to review, as a technologist or as a physician, what do you look for? You're looking for changes in velocity. Here's an example. You start on the MCA, suppose that the flow velocity is 60, and let's say that you're going distally and at a depth of 44, your velocity goes to 120, a distinct change in velocity. Whenever we're distal to a stenosis, we'll have a change in our pulsatility. The pulsatility index will go lower. We want to keep an eye out for that. Sometimes the pulsatility index will be higher than the expected, and then an example of that would be somebody with increased intracranial pressure. We look for changes in systolic upstroke, that tardus type of waveform, distal to a stenosis. Changes in flow direction only mean one thing. A change in flow direction means there's a collateral pathway. We look for side-to-side differences. You know, if your flow velocity in the MCA is 60 on one side and 24 on the other side, certainly there's a problem there. And then we're always listening for emboli, although that's not part of our discussion today. This is what you're going to be looking at when you've completed your exam. So once you load up your waveforms, you see each of the arteries, the MCA, ACA, bifurcation, et cetera, listed here. You can look at these waveforms, you can review them, you can delete them, you can use cursors to remeasure. But then our final finished report is going to look like this. It's two separate pages. We have one report that shows all of our spectral waveforms and any two parameters that you've chosen. Let me come over and show you what I mean by that. So this is showing our mean velocity, and this is showing our pulsatility index on these waveforms. And then the second report is what we call the text report, and that's listed over here. And you see that each artery is listed along with the depth, the mean, the peak and end diastole, as well as the pulsatility index and the resistance index. You could have your Lindegaard ratio. In order for these Lindegaard ratios to show, you must have added the extracranial ICA to your MCA waveform so that the software can do that calculation. So this actually is the conclusion of our session. Aisha, if you're ready, I'm going to hand this back over to you, and we can field any questions that have come in.
Okay, thank you, Katie, for the very informative presentation. If you're using the chat feature, please send the questions to myself, Aisha Upal, or our WebEx host, Bob Nelson. Okay, I'm going to start with the first question that came in, but you can continue to submit any questions while we go through this. First question is, when recording the MCA, we start at 50, go down the 40, and record and take pictures up to 60, then start recording MCA ACA at 60. Should we continue to get pictures above 50?
Am I on? Okay, hi. That's an interesting question, and Diana, I'm not positive I completely understand the question. What I would suggest is that you save a picture at 50, and then save a picture at 40 or however distal you can get. And then the next picture that iCavel says you need to take would be at the MCA-ACA bifurcation. So I would definitely take a picture of the MCA-ACA and then proceed as we described within the presentation. So just to review, you want a minimum of 2 pictures of the MCA, 2 pictures of the ACA. That can be at the bifurcation and about 6 millimeters deeper, or also at the midline. You want a minimum of 1 or 2 pictures of the PCA, 1 picture of the terminal, et cetera. So I hope that's answered the question. If it hasn't, please feel free to either clarify it now or to email us.
Okay, thank you, Katie. We have another question. Is terminal ICA okay for substitute if the submandibular ICA is not available, like if the patient has a C collar?
The answer to that is absolutely not. So the terminal ICA is part of the anterior circulation of the circle of Willis. What we're trying to do when we do the submandibular ICA is to get information from the extracranial ICA. So we want to know, has flow increased globally? Is the submandibular ICA flow high in comparison with the MCA flow, or is the submandibular flow still low? So that's part of the extracranial circulation. The terminal ICA would not be a substitute in any way for that, because it's part of the circle of Willis itself, and we wouldn't get the information that we're looking for.
Okay, thank you. Do you have any tips for verifying you are really on the PCA? It seems like the hardest artery to positively identify.
Yes, I think that's an important question. The things that we talked about earlier, when you're learning to find the PCA, have your patient close their eyes, And then when you're ready, when you're on what you believe is the PCA, have them open their eyes as you turn on the lights. Wait about usually 5 seconds, and you'll see an increase in flow. And then when you turn off the lights, you'll see the flow go back down. The other thing that is helpful is looking at M mode, because you'll see that color band that we described where when you're in the posterior circulation, you will not see color filling at the depths of the MCA down in the 40s and the 50s. And then the other thing that I think this is such an important question. I can't emphasize enough, we teach a technique. If you do that maneuver, so for the PCA, for instance, from the bifurcation, you're tilting posterior and inferior. If you don't get it the first time, try it again, maybe a little less or more posterior, a little less or more inferior. But if you do that maneuver that you've learned and you don't find the PCA, you need to put in your notes, unable to positively identify the PCA. For those of you that were at our collateral presentation and the 3D presentation with John McCartney, if you can remember, about 20% of people have a fetal origin PCA, which means either it's congenitally absent or it's misplaced. So if you're fishing around to find the PCA every single time, you're really doing an injustice to yourself, the patient, and your interpreter, because it will not be there 100% of the time. I hope that answers the question.
Thanks, Katie. I do have one more. You mentioned tracing the MCA to distal depths. What is the significance when the MCA will not trace distally?
The significance is that you are either on a branch of the middle cerebral artery or you're on the terminal ICA. So a big mistake that people make is when they're trying to locate the MCA, they will choose the signal with the strongest waveform, not the highest velocity. So you need to choose the highest velocity, even though that signal may be a little bit weaker, and trace that. Because if it won't trace, again, you're either on the terminal ICA or you're on the a branch. And so if you're on a branch, you need to go back and maybe try a different approach. So you can use a posterior window, a middle window, or an anterior window from the transtemporal approach, and you're always looking for that window that will give you the highest velocity.
Okay. Any more tips on finding the exterior ICA submandibular approach? I missed the first couple of minutes.
Yeah, that would be the extracranial ICA. It's usually pretty easy. So the big thing is not to angle that transducer at 45 or 60 degrees, but put it right underneath the angle of the jaw, straight up at a 0-degree angle, and that flow that is away from the transducer, that will be your extracranial ICA. Now, where this gets hard is when a patient is on a ventilator, and that's just difficult. If you end up, if the patient isn't on a ventilator, but you keep getting the strong respiratory impulse, you could ask the patient just to stop breathing if they are able to cooperate for a moment, and that will allow you to get a better signal. Oh, one more thing, Aisha, before we go to the next question. Keep your power down when you're doing the extracranial ICA. So we usually use a power of 50% or less, because otherwise the signal, you're not going through bone when you're underneath the angle of the jaw there. So keep your power down probably to 50 or 60% maximum. I usually use 27% power.
All right, thanks, Katie. When you turn on the light and it raises the velocity of the PCA, does it take away velocities from other vessels?
That's a good question, and it's an interesting question. The answer is no. It doesn't steal any flow from other vessels. the PCA is the only artery in the circle of Willis that perfuses the visual cortex. It's the only artery that will respond to light stimulation. So because it's perfusing the visual cortex, when we turn on the light, that's that actual artery providing more flow. That's called metabolic autoregulation. So no, you don't have to worry that it's stealing from any other vessels. No other vessel will ever react to light other than the PCA.
Okay. Do you have any tips for identifying the ACA?
Yes. I feel that the most important part of identifying the ACA is to pay very good attention to your waveform at the MCA-ACA bifurcation. So the way that you can be successful with that is, as I said, starting at a depth of 50, you'll have your middle cerebral artery flow towards the transducer. Trace that artery distally to verify that you are on the MCA, and then begin to increase your depth until somewhere between 55 and 65 you'll encounter the MCA-ACA bifurcation. That ACA is, or that lower waveform is the ACA. And then all you have to do is increase your depth and optimize your waveform to keep that waveform away from the transducer optimized on the screen. If you have a very weak ACA at the bifurcation, you can try tilting a little bit anterior and sometimes a little bit superior, and that will help to optimize that ACA. Also, on the Sonara, once you get past a depth of about 60, your power automatically goes down, but you can restore that power as you go deeper. So that would be another tip to help you optimize the anterior cerebral artery.
All right. If there are no more questions, we will wrap up. Thanks, everyone, again, for joining Natus's educational TCD webinar. And thanks again to our host, Katie Vollrath.